Hi everyone, my name's Lizzie Barrett. I'm the nurse educator out at Nepean Hospital in intensive care, and I'm just going to spend 10 minutes or so today going through a really quick survival guide to BiPAP. So this is designed for nurses, maybe JMOs who might be working in a ward-based environment or very new to intensive care. You've done some non-invasive ventilation before, or you've done all the theory, you just need a really quick refresher and a reminder of the core things that we need to do to get up and running on a patient. I have a much more, I guess, comprehensive talk. It's still basic in nature, but that covers, I guess, the theory behind CPAP and BiPAP or non-invasive ventilation a bit earlier in the series. It goes for about 50 minutes, so it's quite long. But if you've never ever done non-invasive ventilation before, it's probably worth a watch, or don't necessarily have to watch my video, but maybe just do some training or some reading around the core concepts of non-invasive ventilation. So again, this talk is generic in nature. It's not designed for a specific facility. So please be familiar with your local policies and procedures or guidelines. There are going to be differences across different campuses, and there are going to be some differences from machine to machine. So utilize whatever resources you have available to you in your clinical setting. Again, this is designed for patients in an acute setting with an acute respiratory failure issue. This is in no way to be taken in the context of chronic patients requiring chronic long-term non-invasive ventilation. So, non-invasive ventilation is, ventilation refers to pressures. So we're applying pressures, and in BiPAP, we're doing that both on exhalation and inspiration, and we're doing that via a mask. So either a mask that covers the nose and the mouth, or a full face mask. We would not use a nasal mask in an acute setting where a patient has an acute respiratory issue. We can't deliver guaranteed pressures because the gas flow leaks out through the mouth. So there are a number of machines that can deliver this therapy. Some of them look quite fancy and have lots of buttons, and some look more basic, but fundamentally they all deliver the same therapy. There are some pros and cons to different machines, but again, they're all going to deliver the same therapy. So BiPAP is a bi-level positive airway pressure. We are delivering a pressure during both the inspiratory and the expiratory phases of breathing. So, as well as delivering pressures, we're also going to be delivering oxygen, and oxygen can be expressed either as a fraction or as a percentage. And I've got the conversions there down on the left-hand side of the screen. Or you can provide oxygen, and this is going to be machine dependent. You can provide oxygen via a wall tap and oxygen tubing. Some machines that draw oxygen from a wall tap will convert those litres per minute that you're delivering into a percentage on the actual machine itself, and some machines won't do that, so you won't be able to see how much oxygen you're delivering in a percentage form, but your order will usually be to titrate your litres per minute to an end effect for the patient. So what I mean by that is that you're targeting saturations above 88 or 90 or 92%, whatever it is that your medical officers have ordered. So if your patient drops down, you would turn your litres per minute up until their saturations come up again. So the pressures that we apply in BiPAP, we're going to talk about PEEP first, PEEP or EPAP. So that's the pressure applied at the end of expiration. And the reason why I talk about that first is because this is the pressure that we apply in every setting. So we apply this in CPAP as well as BiPAP. In BiPAP, we just add in an inspiratory pressure. So PEEP, hopefully by now you're all really okay with PEEP. So when we breathe in and then breathe out, as we breathe in, our pressures in our lungs and airways increase, and as we breathe out, that pressure naturally decreases. And when we get to the end of expiration, the pressure is at the lowest it's going to be in our system. What we want to do is we want to apply a positive pressure, so that essentially what we're saying to the body is that when you breathe out, so at the end of exhalation, I don't want the pressure in your airways and lungs to be any less than 5 centimeters of water. So you can't drop below this 5 centimeters of water. So this is the PEEP that we've applied. So we've got a setting on our machine of 5 because that's what the doctors have ordered for us. And we've put 5 centimeters of EPAP in. Remember, EPAP and PEEP are an interchangeable term. all means the same thing. So as the patient's breathing out, they're breathing out against a positive pressure, which means that their airway and their lung is the pressure inside that cavity and space is not going to drop below 5 centimeters of water. And that's really important because it helps keep alveoli splintered open. So the alveoli are the little air sacs at the end of our airways, and these are the little critters that are actually responsible for gas exchange. So every alveoli has a little capillary bed around it. And as we breathe in and those alveoli expand, oxygen flows from the alveoli into the bloodstream, and CO2 comes from the bloodstream back into the alveoli, and then we expire. And all of that CO2 and gas flow is expelled from our airways. I should have said we exhale, not expire. We exhale, and all of that gas flow and the CO2 is expelled from our airways. When we breathe in, our alveoli open. When we breathe out, naturally our alveoli close down. We breathe in, they open. We breathe out, they close down. When we provide a positive pressure at the end of exhalation, those alveoli are splintered open because we still have this positive pressure inside the airways. So instead of going open, close, they go open, close, open, close. And that means that they can participate in gas exchange for much longer throughout the respiratory cycle. And that's really important because it helps us optimize oxygenation. So PEEP has a direct relationship with oxygenation. In some patients, so the ones that we're putting on BiPAP, we also want to add in an inspiratory pressure. So as they breathe in, we want to give a positive pressure when they breathe in, and that helps them to actually take a bigger tidal volume. So IPAP is the total pressure from baseline to the maximum inspiration pressure. So that's what IPAP is. Pressure support is the difference between our IPAP and our PEEP. So pressure support is our IPAP minus our EPAP, and hopefully that's quite clear here on the graph. So we've got time across the bottom. We've got our pressure measured in centimeters of water across up the side here. We're delivering an expiratory pressure of 5. So the pressure in our airways never drops below 5. So at the end of expiration, when our pressure's at its lowest, we've still got this positive 5 centimeters in there. But then we're also telling the machine, well, actually, we want you to deliver we want you to push air in as the patient breathes in, make it easier for them to take a nice big breath in. We want those lungs nice and expanded. And so here, if we have a look, if we draw a line across, so across at the peak of inspiration here, it looks like it's set at about 12. So I'm going to say that the IPAP here is set at 12. So we've got an expiratory pressure of 5. Keeping in mind, obviously our inspiratory pressure has to be higher than 5. As we breathe in, we're only going to increase pressure. So our inspiratory pressure has to be higher. We've set it here at 5. Now the difference between the two, so I've got a PEEP of 5, I've got an IPAP by the looks of it of about 12. The difference between those is 7. So that means our pressure support is going to be 7. Depending on what machine you have will depend on what it is that you actually need to set into the machine. But you need at least 2 of those numbers. Medical officers will always order us a PEEP, and they will either order you a pressure support or an IPAP, and you can use that little equation to work out what the third number is that you haven't been given. Minimum pressure support of 5. So you want a minimum difference of 5 between your expiratory pressure and your inspiratory pressure. We add in this inspiratory pressure because ultimately it increases minute ventilation. So our minute ventilation is our tidal volume, so the amount in mils we take in a breath per minute times our respiratory rate. We're going to increase that tidal volume, so we're going to increase the amount of mils that patient takes per breath, and ultimately that's going to increase our minute ventilation. Now, minute ventilation has a direct correlation with CO2. So PEEP, positive end expiratory pressure, the pressure we apply at the end of expiration helps with oxygenation. Minute ventilation helps with CO2. In addition, adding in an inspiratory pressure helps decrease the work of breathing. It helps our patients take a bigger breath to achieve that minute ventilation that their body needs. And so often it can actually slow their respiratory rate down. So that can be very helpful as well. So what do we actually need to apply this therapy to a patient? We need our equipment, a circuit, a mask. We need humidification, whether that's an active method, such as a water bath, or a passive method, such as a HME. We need protective dressings for the patient's face. You need to confirm your order. And for BiPAP, your order needs to have a starting oxygen level, whether that's an FiO2, a percentage, or a litres per minute. You need to have a CPAP, which is, again, those terms, PEEP, EPAP and CPAP all mean the same thing. So it's a positive end expiratory pressure, an expiratory positive end pressure, or a continuous positive airway pressure, no less than 5. So 5 centimetres of water would be the minimum you'd set. Maximum in a ward environment would say be 10 to 12 centimetres of water. You can deliver more than that, but PEEP itself has consequences on our blood pressure, and we need to be mindful that keeping a patient who's on high levels of PEEP in a ward environment might not be in their best interest. They might actually need some closer observation and monitoring, or they might actually need a change in their ventilation settings. Do they need to go on to BiPAP if this patient's just on CPAP? If the patient's on BiPAP, not only do we have a PEEP, we actually need an order for an inspiratory pressure as well. Now, pressure support, minimum of 5. So we want a minimum of 5 centimetres of water difference between your expiratory pressure and your inspiratory pressure. Less than 5 difference, you don't really see much of an effect in terms of increasing tidal volume. So minimum of 5 centimetres of water of difference. In terms of a maximum inspiratory pressure, no higher than about 28, again, in a ward environment. Again, we can do more than this, but you can't just keep blowing the lungs up and up and up. High pressures have an effect on the lungs and it can become dangerous. That patient, again, probably needs closer observation and monitoring, either in a high dependency or an intensive care unit. Once you've got all your equipment, you've set it up, you've programmed the machine, you're happy with your order, you need to explain the therapy to the patient before you apply it. You staying at the bedside and providing reassurance and support to the patient will be one of the big factors that leads to success with the initiation of therapy. So please don't leave. Some people, they'll take to it really quickly. Some people need, 15, 20 minutes of reassurance. Some people need more than that, like you constantly going back to them and helping them concentrate on their breathing, take big breaths in, work with the machine, etc. When you start the machine, you want to apply the mask to the patient's face. And my personal practice is just to hold the mask until the patient has settled, they're working well with the machine, before I attach the head straps, fasten them, and then assess for leaks. Circuits, and if you've watched my previous talks, I appreciate this gets a bit repetitive, but this is quite important. There are 2 limb circuits. So there are circuits that have an inspiratory limb and an expiratory limb and are sealed. And there are circuits that only have an inspiratory limb. In these circuits, you need a vent or a hole in the mask or the piece of plastic immediately adjacent to the mask for exhaled air and CO2 to escape. If you don't have that, the CO2 is going to stay trapped in the patient's mask and they're just going to rebreathe it, and that is very dangerous. In COVID times, some units put a bacterial or viral filter on that exhalation port. So just adhere to your local policies and procedures in regards to that. In terms of assessing response, you want to do a really good physical assessment and a really good respiratory assessment to see if this is working, your therapy is working. In most patients, you want to see an improvement within the first 60 to 90 minutes. And they obviously, we're not going to completely fix them in that time frame, but we want to see their work of breathing decreased. We want to see maybe a slight improvement in saturations. If we're not seeing that improvement in 60 to 90 minutes, we really need to start thinking, okay, are they on the right settings? Do we need to change the settings around? Do they need referral to be nursed somewhere different, whether it's a specialty respiratory ward or the intensive care unit, because they need closer observation or monitoring. So I hope this talk has been useful for you. Happy for any feedback. Please contact me if you have any comments. Stay well, stay safe.